Coming up on Why Should I Trust You? Dr. J. Bhattacharya, the director of the National Institutes of Health of the United States and the acting director of the Centers for Disease Control, is our guest today. We want to talk with him about his goals and his philosophy as he leads the world's largest biomedical research ecosystem. How does someone who has so vocally lost trust in federal health agencies now approach leading not just one, but two of them? And nearly a year in, does he think trust is coming back? We want to ask him about all that's gone down at the NIH with funding. Is this much-needed disruption in the name of progress and innovation? Did the NIH lose its mission? Has the agency become too focused on ideology over science that would actually improve Americans' lives? Has it been funding too many studies that don't lead to Americans living longer or better health outcomes? Or what is happening now, a dismantling of the world's premier scientific research engine, our engine of American innovation, one that the overwhelming majority of Americans consistently say they are not in favor of cutting or disrupting? And what does Dr. Bhattacharya have to say to all the scientists who tell us they're living in fear of uncertainty, that they'll lose their funding to do that research? Is this all just growing pains in service of a bold new vision? And finally, as someone who thinks deeply about trust, is he confident he can rebuild it? Let's get started. Welcome to the show, everyone. We have a very special guest today. As we said, Dr. J. Bhattacharya, the head of the NIH, and now also the acting head of the CDC, is here. We have wanted Jay to come on the show for a while now, and we're excited that he said yes. We will get to our conversation in just a moment, but first, who are we? I'm Brenda Adhikari.
I'm Tom Johnson.
And I'm Dr. Mark Abdumalik.
Yeah, and Maggie Bartlett is in our producer role today because we need one. It's a big show. And just a reminder, this is Why Should I Trust You? It's a podcast that explores the breakdown in trust in public health, science, and medicine, and what we might be able to do to get some of that trust back. You can always reach out to us. Just send your thoughts and your questions to questions@whyshoulditrustyou.net, and always check out our Substack page.
Okay, so just before we have our conversation, Tom, tell us a little bit about his background.
Yeah, so just some basic facts. For roughly 2 decades, Jay Bhattacharya, who is a health economist, was a professor at Stanford University. And during the pandemic, he said the public health response shattered his assumptions about how science and public health institutions operate and how they should operate. And he became an outspoken critic of the federal response, particularly the lockdown policies and those prolonged school closures. In October 2020, he was one of the authors of the Great Barrington Declaration, which argued that COVID data at that point had clarified who was most at risk, primarily the elderly and those with underlying health conditions, and proposed a focused protection for those groups while allowing lower risk, younger people, healthier people to resume normal activities. This was a proposal that was put into the mix, and it was very controversial. And that proposal remains very controversial still to this day within the science community. And when Donald Trump appointed Robert F. Kennedy Jr. to lead the Department of Health and Human Services, the president then later selected Bhattacharya to head the National Institutes of Health. This, of course, is the nation's primary funder of biomedical research. It distributes tens of billions of dollars annually to competitive grants. Bhattacharya has been at the helm of the NIH since last April, so he's coming up on a year.
So as head of the NIH, Dr. Bhattacharya basically sets the broader scientific agenda while also determining which specific research priorities rise to the top. And just 1 week ago, he made history when he was named acting director of the CDC. And that's the very first time one person has led both agencies at the same time.
Okay, and now our conversation with Dr. J. Bhattacharya. Dr. J. Bhattacharya, welcome to Why Should I Trust You?
Great to be here. Thanks for having me on.
So we thought we'd be interviewing you about one job, but it turns out you have two. You're brand new to the CDC. How are you literally going to do two jobs?
Yeah. So first, I have worked very hard this last year at the NIH to put in place a leadership team and a set of ideas and priorities. It's much more stable than it was last year. I have full confidence, and they're fantastic. The team at the NIH, and I'm working, continue to stay in touch with them continuously. I think that's so. I think that I don't think it would have been possible if I started at the beginning of last year with 2 jobs. That wouldn't have worked. The CDC, I just got appointed as acting director. It won't be permanent. That was going to be a full director. But I spent all of this week in Atlanta. I intend to go every week, go visit there. There's first, I should say, a tremendous amount of talent at the CDC and a desire for public health to succeed, for people to be healthier. It's been a tumultuous year, I think, at the CDC, but but I think it's a solid organization that just needs a little bit of leadership and love, and so I'm gonna work on that. It's been fantastic meeting so many great people at the CDC, and over the next few months, what I'll do is I'm going to work on getting a leadership team in place, renew its sense of vision and mission. And get it spruced up so the next leader can take over and just run with it.
Yeah. So Jay, we're so excited to talk to you because, you have made it very clear to the American public that one of your big missions is to rebuild trust. And that is something that we've spent the past year exploring. To be honest, it's a humbling, hard thing to do. And I'm sure you're experiencing that too. This is not easy. There's just so much work to do, and it's not always clear as to how you do it. So I guess just we're curious, how is this going so far for you in building trust back? I mean, the polling, as much as we have it, I sort of see one group that maybe felt broken in terms of its relationship with these agencies is maybe inching up, and the other group that felt more trustworthy of these institutions is dipping down. It's like a seesaw effect. I mean, just if you're honest, how is that mission going?
Yeah, so thanks, Tom, for that question. I mean, that's the central thing that I'm trying to do. I mean, reforming science and reforming public health are essentially, to me, obviously important in themselves, but the purpose is to rebuild that trust. And I'll tell you why I think that's important, because I don't think science and public health can succeed without that public trust. So to answer your question, let me just start with the standard I'm holding myself to. It can't be a matter of polling where you have 50-50. If you have 50 plus 1, you're a successful politician, right? 50% plus 1. If in public health we get 50 plus 1% support, or in science 50 plus 1% support, that's a failed mission, right? We need basically near universal confidence. Not that everyone will agree with everything that comes out of public health or out of science, but that everyone believes that there are standards to which we are holding ourselves. Gold standard science, a commitment to the health and well-being of the public. All of that it has to be basically near universal for us to be successful. So in that sense, Tom, we're very far away from that. And I'll tell you, I think the reason is really, to me, so clear. It's because what happened during the pandemic was an absolute breach of trust by scientific leaders, and also by public health leaders. And it's why you see that polarization. I mean, if you go back before the pandemic, of course, there are people that didn't trust scientists, but it was a relatively small number of people. And of course, there were people who just disagreed with aspects of public health. But the sort of connection that public health had with the community was much deeper, right? There's sense that we're all in this together. What happened during the pandemic was both public health and science came to be seen as overlords, like dictators almost, with powers that were unimaginable. It was used to keep our kids from going to school for 2 years in person. It was used to prevent you from having funerals for your family members. It was used to violate basic civil liberties at scale for years in the name of science, in the name of public health. And nevertheless, the COVID hurt so many people. It didn't work. So I can fully understand why there's that now. And then you overlay on top of that politics. And that's why you get the 50-50 thing you talked about, right? Where some people are more trust. As soon as like some other leader more aligned with the left takes over, the left will start to trust more, and the right will start to trust less. That means that we are, whatever that system is that we currently have is fundamentally broken.
Jay, we've heard you speak about the trust that was broken during the pandemic. And now it appears that there's also trust broken in one widely reported topic that, again, many of us who come on the show tell us is continuing to cause quite a bit of mistrust, and that topic is the major disruptions and instability to NIH research in the past year. So, look, to the average American, the NIH is the main engine that funds scientific research and biomedical innovation. And in the news last year, the news last year was fairly dominated by headlines about the NIH cutting research. So, I had the privilege of attending a Maha Institute event, which you hosted, and we chatted at that recently, and you addressed the issue of funding cuts by saying, quote, "There haven't been funding cuts. There's been a shift in the agenda to make science work for the people. It's a time of hope because with those changes, there are investments now made to make our future much brighter." You went on to say at another point when this issue came up, quote, "What funding cuts? The Senate and House are about to pass bills that fund us at a higher rate than last year. I've never fully felt in the core of my soul what fake news is until I started reading that we're cutting everything at the NIH. It's a political ploy in order to resist the change that we're bringing." So, Jay, help us understand, what exactly do you mean when you say there haven't been any funding cuts?
I mean, literally, there have not been any funding cuts. It's literally the case that the NIH budget was, I think, like $48 billion in 2025. That is passed by the previous Congress. And the budget passed for 2026 is about $50 billion, an increase in spending allocated to the NIH by the government. And so it's literally the case that there's been no funding cuts. And yet you have this widespread reporting by the news media that there's cuts. It makes absolutely no sense. It's literally fake news. It's at odds. You could go look. What is the budget? It's just math. It's just numbers. What has happened? Oh, sorry, Brenda, you were about to say something.
Yeah, well, I was going to say, so I think what I'm hearing you say is that you drew down the budget. And so let me just present you with this, which is the congressional.
I'm sorry, what do you mean by drew down?
What I mean is you were allocated a certain amount and you spent that amount. Is
yes.
What you're saying. Okay.
So before you get to that, let me say one other, because there's one other aspect of the thing you said before I want to make sure I address. Mm-hmm. We have shifted our priorities, right? No dangerous gain of function, no politicized science. And so what that's meant is that some people who were funded with the old priorities are no longer funded. And that means there are new people who weren't funded before who are funded. I think what you're seeing in the news media is the people who were funded, the scientists whose agendas were funded previously, that are no longer priorities of the NIH, that I believe, and the reason that they're no longer priorities of the NIH is because I think they didn't actually produce results that would be, make people healthier. They're complaining to the news media they're no longer funded. But that is not the same thing as not funded. Like the total overall funding level is the same and actually higher this year.
So let me, because we wanted to make an effort to kind of get the data from a more nonpartisan arm, because we've heard you talk about
nonpartisan. Literally, Congress passed a bill. You can look at the bill.
Well, let me offer you this one statistic and just get your thoughts on this. So the Congressional Research Service, which is the nonpartisan research arm of Congress, it's the one that Congress people go to be like, hey, I have a question on this. Can you offer me some stats? They cited data through November of 2025, and they determined that HHS terminated 977 NIH grants totaling $1.7 billion in roughly 10 months. Do you agree with those numbers?
Yeah, but that money was then spent on other science. I'd have to double check on the exact numbers because it's hard to, there's a lot of, I haven't seen that particular report, but the point is that money was diverted and spent on other science.
Yeah.
The science. So the question isn't, is there a reduction in support for science? It's what science is supported. That's the question.
Yeah. So if you talk about what science is supported, I think the reason why we want to get into this is because we want to remind people that this is like tax dollars. You talked about the budget that was spent. This is money that is, Congress is ordering, you to spend to answer the hard scientific questions, basically to deliver discoveries that shape how well we live. Do Americans live longer? They looked at the number of trials. So you said that you had this bucket of money and you needed to spend this like amount of money. And in 2026, that number is significantly lower than we used to do.
That's not true, Mark. That's not true. So it's higher in 2026. The budget allocated to the NIH is higher, significant, like by about 1% higher than the previous year. Which again, the estimates are like $48 billion in 2025 budget.
The dollar amount is higher. I don't think anybody's arguing that. The dollar amount is higher, but we getting less science?
The total support for science is higher. I mean,
but are we getting? Let me just ask you this question, because are we getting less science for our money? So in 2026, NIH.
So now that's a great question, and the answer is no to that question. Right. So in particular, what was cut? What was cut was funding for dangerous gain of function. That's not actually science that's worth doing, right? Because it puts the population at risk of lab leaks and catastrophic harm. What was cut was DEI. DEI. There is no good argument I've ever seen that suggests that DEI funding has led to any improvement even in minority health. What is now funded? Let me give you an example of how we've changed things so that to directly answer your question about what was funded. The NIH funds research on every imaginable topic, from autism to Alzheimer's, from heart disease to rare diseases. We have programs to fund all of those research and all of those things. I did a research project a few years back before I was NIH director, where I asked how close to the cutting edge was NIH funded research. For this project, basically, I figured out how old were the ideas in published research by NIH funded researchers. In the 1980s, NIH research for published research was at the absolute bleeding edge. Ideas that were 0, 1, or 2 years old, right? And I can describe to you how we did this estimate, but then it was published in the Proceedings of the National Academy of Science. You can go look at the methods. In the 2000s and 2010s, the typical NIH-funded research was working on ideas that were 7 or 8 years old. And so what has happened is essentially the NIH had become used to funding the same ideas over and over because it was safe. I put in structures so that the NIH goes back to funding research that is the cutting edge. That means that researchers that are used to getting their money because they're doing research that on ideas that are 7 or 8 years old, it's fine. They're going to produce papers, are less likely to get that money than researchers that are proposing brand new ideas that are at the cutting edge. New researchers, different ideas. They're all as far as the actual areas themselves.
You're describing that we kind of did like little incremental things instead of like big shift, big ideas. And you definitely want to get back.
Exactly.
And so you want to shift to big ideas. But again, I just, if you just look at the number of studies that used to be funded, and let me just say this, in 2024, let's say there were 10,000 grants that were funded. In 2025,
so our portfolio is about
6,000.
It's about 60,000 grants. Those numbers are, I think you're not right.
So I'm reading from the Congressional Research Service, and in 2026,
the estimates I have on new grants, we had about 8,000 new grants funded this year and other projects. I don't know. So when you have these numbers, what you have to see is like what exactly categories are people looking at. So we can go back and forth on this, but I'll just tell you.
That significant amount of drop, are you really saying that everything that you eliminated? So Mark,
what that means is that we have larger investments in each project.
And does it have anything to do with the way, like, I just want to understand, because these are just really like just straight up numbers that the Congressional Research Service is reporting. Is it related to how we fund studies? Like, help me understand that. Is the accounting different? Is it that we used to just fund studies at instead of giving you a lump sum, we would like give you a little bit each year, and now we're moving to giving you a lump sum? And is that the reason why we have less studies funded?
That's part of it. But again, on that, the reason why to do that is if you're funding a large study that's on a new idea, you may have investments that you need to make in equipment and so on up front that you'll use for the lifetime of the study, which might be 5 years or something. And so, like, allowing that be a lump sum up front then allows you to go in a new direction. Whereas if you're just funding incremental work, you can fund lower for five straight years or whatever. I mean, it's there's tens of, actually, it's the numbers I have are something like 8,000 new studies. Our portfolio is still about 60,000 studies that we're funding that are continuing. So I look at the narrative on this, and it just seems utterly ignorant about how actually grant funding decisions get made. The question isn't about the total amount. The total amount of spending is higher. The question is the quality of the projects that are funded.
Well,
And
so let's talk about that for a second, Jay, because what I'm hearing you say is that, it was the projects that were not funded or terminated were misaligned with the priorities of NIH and they were DEI, right? And so some of the ones we called around to some schools that are still haven't seen their grants either unfrozen, just to see, like, is it all just DEI stuff? And here are some of the studies that we learned about.
Okay, so
for instance, just so I can keep going on just this.
Before you launch into the list, let me just say, the way that we fund studies, right? You may read me a title, right? But the question is the thing that was cut, so for instance, there was a whole bunch of studies with great titles. And then at the end of every year, the NIH has some money left over. They go back to the investigators and say, "Oh, well, we can give you a diversity supplement. Same title, but it's a diversity supplement on top of this."
So what you're saying is, when I read you this study, mitochondrial-based determinants of sex
so
differences
that's a good example.
in acute kidney injury.
So that's a good example. So very often, I'd have to go back and look specifically on that study, but very often in fact, I can tell you in every case that you're going to read between me, almost every case is a diversity supplement, right? It's an add-on to the grant at the end of the year for DEI purposes.
So Jay, I'm going to say this, which is, if that is the case right now, I think part of the narrative, which truly as the public, as a non-scientific person, there is the impression that there were a bunch of bros at Doge that, like, put in Chat GPT, hey, is this grant have race in it? And they eliminated grants based on that. But what you're saying is that the NIH did a careful review of every single grant that was terminated, and every single one of them that was terminated, in the body of the grant application or the grant that was approved and then terminated, there's a diversity supplement.
Well, I say there's some element of out of alignment, like DEI, politicized science rather than actual science. I'll tell you one other thing that we did is that in all of these cases where it involved termination, we went back and we negotiated with the reviewer, because often what you see is some excellent science intermingled with politicized science. And we went and negotiated and said, look, if you take out the politicized science, we want you to do the excellent science. Most researchers actually want that. The politicized science happened because essentially the previous leadership of the NIH decided that they were going to use the NIH for social justice purposes rather than for science.
Can we share with your team, just so that we're all on the same page about the disruption, even just so we understand, because we hear from scientists who are like, mine had nothing to do with anything involving what they're objecting to. It literally was like studying substance abuse in urban use, or metabolic decline.
So there's one other category, can I say, of things that were terminated and or disruptions, and that had to do with institutions that were violating the civil rights laws of the country. And so for instance, Columbia, right? There was a huge amount of disruption over pausing grants to Columbia because they were violating the civil rights of the Jewish students. And the administration, I think, appropriately took action to try to essentially have these institutions stop violating the civil rights of the people. And they use the NIH as a way to sort of induce them to start following the civil rights laws of the country. Bob Jones University in the 80s, federal funding got cut to this because they were racist back then, and so it was an appropriate action by the administration. So some grants got caught up in that. As soon as Columbia came to terms and started making a commitment to follow the civil rights of this country, civil rights laws of the country, we turn back on their grants. So you can read me titles for I mean, there's other universities as well of grants that which I would agree with you is an appropriate use of NIH money if it were to go to an institution that is not violating the civil rights of the country, laws of the country. But that doesn't.
So what you're saying is the scientists may have the best of intentions in the grant, but if the institution that they're from is violating the civil rights, then the scientists will also kind of get penalized in that moment.
Yeah. I mean, they're working for an institution that is racist or that is like violate anti-Semitic, right? And so that, you know, like I said, there's a track record in history that goes back to the 1980s where the federal government decided that it was going to stop funding Bob Jones University. It went to the Supreme Court. You can go look it up. Where the violation of civil rights meant that the federal government will not fund that institution until it becomes in compliance with civil rights laws. I think that's entirely appropriate.
So,
now,
Jade, just on that point, and then I think we want to zoom out a little bit and sort of talk about where we are, where we're going. But you've talked passionately about removing ideology from science. You don't want ideology dictating science. I mean, wouldn't that, just on this point about the White House, you know, pressuring a campus to change policies, they could be good policies, abhorrent policies, but using science as the leverage to do that, cutting science. Are you for that?
If you have an institution that is violating the civil rights laws of the country, the federal government shouldn't be funding. You shouldn't be using taxpayers' money to support it.
Right. So
yeah, I'm in favor of that.
I'd not heard you say that, and that's interesting to me. That there are times where science needs to be cut for.
Okay, so again, now that science was so like take Columbia. Science actually did not get cut. Once Columbia made a commitment to follow the civil rights.
Sure, but science was stopped. You know, participants could leave. Studies have to be shut down.
I'm not saying like it's federal funding, right? So we're talking about taxpayer dollars. I don't think taxpayer dollars should be used to fund institutions that are racist. I don't think taxpayer dollars should be used to fund institutions that are anti-Semitic.
Yeah. So Jay, you know, if that is sort of like how it went down, do you at least acknowledge that that is a significant disruption to those American taxpayers that you just said, who were in those trials, maybe when the axe went down and that funding, was cut? So what happens to those people?
We paused funding in 2020. The NIH paused basically the vast chunk of its investments in clinical trials. Actually ended it during in the pandemic. Just the clinical center here alone, almost every single clinical trial was paused or terminated.
That was in an emergency phase, you mean?
I mean, so the point is not that the trial. There's no history of trials. Trials get stopped all the time because there's a finding that the treatment arm actually was performing much worse than you anticipated. You stop the trial. Like that's a normal process of clinical trials. Clinical trial is not the same thing as patient normal patient care. There's supposed to be normal patient care in addition to the clinical trial. Otherwise, you can't be part of the clinical trial, right? So
But are you saying that those disruptions last year?
Let me just finish.
Yeah, okay.
Right. So when we paused the clinical trials, and this happened in 2020 and happened now, we make sure that the researchers have the resources they need to make sure that there's continuity of care for every single patient in the trial. Right. So that's as far as like patient care being disrupted, as far as and I have like final numbers now, just in the last few days, for how many trials were actually completely terminated. It's about 13 trials total.
And I know that's disputed because there's that 300 trial number with 74,000.
Yeah, but we've done a replication study of that JAMA study you're referring to.
Yeah.
That JAMA study was using a list from July. It confused the difference between paused and terminated trials. And it just didn't have the sort of the right list. In July,
well, they went to clinical trials. If I understand it correctly, they went to the actual clinicaltrials.gov website and basically looked at and to see. Let me just say what they did, as I understand it, is that they looked and said these are the trials that admit that they get funding and these are the trials that then had some sort of disruption to their patients.
So Mark, I thought what they said is that these were the terminated trials, and they'd give the number 300. That's just false. Those trials were not terminated, right? They were renegotiated, as we said, or they were part of Columbia or some other institution that was engaging in anti-Semitic practices, or they. But ultimately, at the end of the year, not in July, they took an outdated list from a secondary database that was actually not an accurate reflection of our portfolio. When you do the actual list, it turned out total actual terminated trials about 13.
Will you send us that data? Wait one second.
Yeah, absolutely, Brenda. So we're working on a.
If you can send us that data, that'd be awesome. Jay, I want to say just one thing on this, which is you were talking about the civil rights, that if a university is being racist, then we need to cut their funding. I guess my question should that be part of a dialogue to determine whether or not that university is being racist? I think one impression that people have is that sort of came down as a dictate from above, and some universities are like, wait, we didn't even get a say in this, right? So do you agree as a free speech,
Brenda,
you believe in the religion of free speech?
Just take Harvard, right? So Harvard lost a lawsuit that went to the Supreme Court, where they found what the Supreme Court ruled essentially that they were discriminating against Asian Americans for a generation.
But then they changed their policy, right? So why are they being punitive? Why are we being punitive to Harvard?
I think DOJ determines whether they're violating. I mean, this is their standard practices for deciding. I mean, I'm not the one making the determination about Columbia. It's DOJ that makes that. It's not me that's saying this alone, right? I have to act based on what the determination is regarding these institutions, based on a whole bunch of criteria that the NIH alone doesn't determine. But I'm completely in favor of not funding institutions that are racist. Are you in favor of that?
I'm in favor of a free speech dialogue where universities.
I'm in favor of free speech.
I'm in favor of free speech. You asked me a
thing,
question,
right?
so let me just answer.
Brenda, are you in favor
I'm in favor of free speech dialogue that engages in a conversation, in a good faith conversation with people to determine whether the university is in violation.
Brenda, that's different than what I asked you. Are you in favor of funding research institutions that are racist?
But are you in favor of the federal government telling
you guys seriously? I'm
answering
all your questions.
I think
I'm answering your question in a question, which is: are you in favor of this administration dictating to a university
Tom, why
policies?
don't we start by the baseline? Are you in favor of funding a research institutions that are racist?
No.
If at the end of a process they're found to be racist, yes.
No,
You're in favor of funding them?
No. If at the end of a process they're found to be racist,
like a Supreme Court case, for instance, where
Jay,
there's a.
But that's not. Is that racist?
Jay, you
discriminating
yourself,
against Asian Americans? Yeah, it's racist.
Jay, you yourself have literally said that we need to decouple this idea of structural racism from science. You've talked about that so many times, and it's just are you able to say that and say that structural racism doesn't exist, and at the same time kind of ask this question?
Okay, Mark, I never said structural racism doesn't exist.
You said structural racism.
Mark, okay, so if you're gonna kind of quote me, you got to get it right. What I said is that a scientific question that has as a hypothesis, a null hypothesis, that scientific racism is responsible for some health outcome. Well, that's not actually scientific because there's no falsifiability of that question, right? So if you have structural racism, the hypothesis is that all the social structures are so inherently racist. That it determines all the outcomes. Well, how would you produce a control group to test that hypothesis? That's not a scientific question.
But Jay, it sounds like you're okay with going with SCOTUS's determination that a university is racist, but yet you're applying a certain rigor to studying structural racism in science. I just want to understand the difference.
So you have to understand, right? So we are using taxpayer money. I have to follow the law, right? So the law is Bob Jones from 1980s. The federal money should not go to racist institutions. It should not go to anti-Semitic institutions, right? And so the administration, DOJ, and others make a determination which of these institutions are worthy of this sort of the designation, and then I, as the NIH director, have to follow that law. Right, I'm not against that. So, and now as far as determination about when we fund an institution, what projects to fund, Yeah, that has to be absolutely scientifically based. And that's exactly what we're doing, right? That's why I removed DEI from the portfolio because
I want to talk about that next. Are you ready?
I thought we already talked about that, Brenda.
No, we're going to talk about DEI because I think it's something
in fact, I just mentioned this, right? So, for instance,
Yeah.
the hypothesis that structural racism is responsible for health outcomes, that's not scientifically testable, right? The hypothesis itself is of a nature where you couldn't even create a control group in principle. Right. So it's not science.
I want to shift to something more specifically on your.
I thought we want to talk about DEI. I mean, which is, yeah.
I want to shift to something you've spoken a lot about, which is DEI. In an American Spectator piece,
I literally just explained, right? So we are talking about a DEI, but the nature of the kind of DEI projects that we cut. Right.
But let me just get a little bit into detail because I think we really want to understand where you're coming from on this. So let me just this is your own words with your deputy director, Matthew Memoli, where you wrote, quote, "For its entire history, NIH funding decisions were made to reach scientific goals. DEI drove decisions to be made for political reasons instead." You went on to talk about the de facto loyalty statements that scientists were made to write in order to get hired or promoted or even funded. And I'll tell you, Jay, even the practice of these diversity statements, like I've heard from several people in the university system that they found them to be performative and problematic. So it's definitely come under.
Let's just describe what they are. They're loyalty oaths.
Yeah, right? And I've heard them described that way. It's come under criticism from many. Like it's a bipartisan.
Is it bipartisan, Brenda?
I think there are some folks on the left who've criticized it.
Why did we have such these basically it was a standard thing in academics and at the NIH?
I think it's becoming a big source of conversation, and a lot of them are starting to go away. But you go on to say in that piece, the NIH will not fund research based on ideologies that promote differential treatment of people based on race or ethnicity, nor will we fund studies exploring broad, poorly defined concepts such as racial microaggressions or implicit bias. You then say, quote, "Chronic disease does not discriminate and DEI is not the solution." So I guess my question in this case is, and I genuinely just want to understand, doesn't the data show that chronic disease kind of does discriminate? Like it's undisputed that Black Americans face disproportionately worse health outcomes.
Brenda,
go ahead.
This is a rhetorical flush in an op-ed, right? So just obviously there are differences, biological differences, and the NIH portfolio accounts for those biological differences. And different people from different populations have different rates of disease. Again, we take that into account. That's not DEI. That's just fundamental biology. I mean, I have the NIH mission is to improve, to fund research that improves the health of every person, improve the health and longevity of every person. I take that very, very seriously, including the health of minority populations. We have a robust set of investments on diseases that are more likely to afflict minority populations than non-minority populations. I'll give you an example of sickle cell anemia, right? It's a whole host of investments because I care about the health of minority populations. My point is that this politicized DEI did not help in any way the health of minority populations. All it did is politicize science. We started with lack of trust. The title is lack of trust, right? So what it did is it sent a signal to the American public that science is left-leaning, attached to the left. This is why I would push back with your thing about the loyalty oaths. You say it's bipartisan. It's not bipartisan. Let's just be completely blunt, right? It was put there by the left. In order, and it's the echo. It's sort of a reflection of the McCarthy era loyalty oaths.
I guess what I mean when I say that is that I am, in my own experience of talking with people in academia, that they are now also saying that was too much and that they're starting to want to pull back from that. Whether or not,
because we've taken action to say that we're not going to fund racist institutions.
So Jay, one thing that I'd love to, so we just in doing research for this conversation, we were asking a few people who I think who are like genuinely just a little bit confused about how they approach, their own grant writing, their own sort of seeking to do research with the NIH in this moment. And they're just seeking a little clarity. So I want to play just one piece of sound from a young researcher who just told us like, hey, if you can ask him this one question. It's like a little less than 90 seconds. So.
My name is Michael Green. I recently finished my PhD in population health sciences at Duke University, and I'm a recipient of an F99 K00 award from the National Institute on Aging. That program is designed to support early career scientists through their PhD and into a postdoc. I'm a Black man in his late 20s who comes from a family where a lot of people stopped going to their doctor for preventative care because they felt like they weren't being listened to. By the time they came back, it was often too late. My grant focused on studying how patient-reported discrimination in healthcare settings is associated with cardiovascular and cognitive health outcomes. It was peer-reviewed, scored competitively, and awarded in August of 2024. In July 2025, NIH told me my grant needed to be renegotiated to remove what they called DEI activities. They gave me a week to rewrite 70 pages of work. I asked for specifics on what was flagged, and I received none. So I removed the word Black from my grant and references to evidence on why Black adults report feeling mistreated in healthcare settings. I didn't change my scientific approach at all, just the language. And I didn't have a learning moment from the process because I still don't know what a DEI activity is in the context of my grant. No one told me. It's now late February. I'm unemployed. I have no health insurance. I haven't received a paycheck since I graduated in December 2025. And out of the 69 recipients of this award at NIA, I'm the only one who has ever had to change the title of the grant beyond punctuation and spelling.
So, Jay, what would you say to Michael Green in that situation?
I'd say that he didn't take advantage of the opportunity to rethink his grant. Like, we gave him the opportunity and he didn't take advantage of it, right? So he, again, I didn't know this grant specifically, but like I'll tell you, like based on the title, what I hear is a grant where it has as a premise something that in principle couldn't have a control group, and so it's bad science. Right, so
So what would have made it better?
Just okay. Let me just finish, Brenda. So I think if I say that provisionally because again I've not read his grant. So, but based on that 90-second snippet, he had the opportunity to be more specific about his hypotheses, make them actually scientific, make arguments for control groups. We gave him that opportunity, and he didn't take it. That's what I'd say.
So let me ask you, is it worthwhile? Because I know that one of the things you have talked a lot about is improving health outcomes. Do you believe that there is scientific merit to studying the role that discrimination plays in health outcomes?
What do you mean by discrimination?
That when a patient goes to a doctor and the doctor has, is treating Black patients differently than other patients, that can lead to poor health outcomes, and that's worthwhile to study.
So Brenda, so you said earlier that minorities may have different health, health, biology or other things. Doctors ought to take that into account, right?
I guess what I'm saying is, are you denying that?
I'm not. Don't put words in my mouth, Brenda.
I'm just asking a question. Are you denying that Black Americans face discrimination at higher rates when they're in a medical system?
What do you mean by discrimination?
So, for example, that let's say somebody goes in and they have pain.
Mark, are you saying that doctors are racist? Is the hypothesis that doctors are racist?
I'm not saying that doctors are racist. I'm saying that
I'm saying is the hypothesis that you're putting forward that doctors are racist. I just want to be specific about what you mean.
Yeah, let's be specific. His hypothesis, if you the study.
I don't know. I mean, we don't know his hypothesis.
Okay, well, just in general, the hypothesis is we just want to understand what factors are associated with poor health outcomes. For example, is that a legitimate hypothesis?
That's vague, but yeah, I want to know why people have bad health outcomes. That's something we're interested in studying. But
so that's a research question.
That's a vague research question. I want something specific. That's
okay. Here's something specific.
And actionable, right?
Here's something specific. Okay, you go to the doctor, and we've heard this that Black women aren't really given the same attention as, say non-Black women in terms of pain scores. Or, sometimes you go and you want to study.
Wait, hold on. That's an outcome. That's not a hypothesis.
I'm just asking research questions. I'm not.
That's not a question. You just give me an outcome. I want a research question.
The question is, why is that happening? Why does that happen?
That's not a hypothesis.
So make it better.
I've got one for you. Yeah. On the pain notion. There was a study I read once that said Black patients, white patients come to the ER. They, looking back at their medical records, researchers found that presenting the same problem using sort of the same words to describe their pain, the clinicians treated more aggressively the pain and investigated the pain issues of the white patients more than the Black patients. This sort of gets us, I think,
Okay, so
maybe
that's
to a
again,
topic
that's an
of
outcome
bias.
difference, not a
Yeah,
mechanism.
but let me
right?
finish.
So, yeah.
Is there room in your thinking for exploring, investigating bias? So in other words, if I said to you, I want to propose an intervention for new training for ER doctors that would reveal to them possibly that they have bias towards
Okay, so
one type
now,
of patient.
Tom,
Another.
you have to be.
Yep.
There is, but the question is, what do you mean by bias? Often, when people say it, they're
Sure.
very vague about this, and they put forward hypotheses that are not testable,
Right.
where they've essentially assumed the answer. Now, there's another element of this, right? So, we have as our mission support for biomedical research that improves health and longevity. Right, so there's a scope of what we do. So we're not a full scope social science agency where the rule I have in my head that I've articulated is that first it actually has to be science. It has to be specific. It has to have actual hypothesis that's testable. Right, so that's why I'm pushing back with you all when you're giving me vague questions instead of actual rigorous hypotheses. Second, it has to be actionable, right? So, yeah, let's say the hypothesis is that structural racism causes higher rates of hypertension in African American populations. Suppose contrary to fact that you could actually create a control group and test it, and you find it's true, right? Then what would you do about it? Right. And then third, it has to be in scope, right? It has to be biomedical research, so something about the healthcare system or biomedical research. Those are the three rules we put forward. Those are very, very clear rules. Scientists, I think, who are well trained understand the difference between a politicized hypothesis that's not actually scientific, that's not actionable, that is far outside scope versus things that are.
So if I said I want to study why black patients with identical injuries receive less pain medication than white patients and test whether maybe a standardized protocol could close that gap, you would say,
yeah,
thank you.
Okay. So let's move on to something else, just because you happen to get the second job of yours now. So you're the head of the CDC, which right now means that you're going to oversee this, ACIP committee, which makes recommendations for our audience about changes to our vaccine schedule. We had on our show a few weeks ago, Dr. Kirk Milhoan, who is the head of the ACIP committee. He said a few things to us that I want to run by you now as the person in charge of the CDC.
Okay, just so we're clear. So ACIP consists of I forget how many members, like 15, 20 members. And there's, I'm sure you saw the last bit. It's not just one member that decides what the recommendations are.
Yeah.
And then on top of that, there's they make recommendations as CDC director. I'm still new to the job, so I'm still figuring that out. But the CDC director gets the last word about this, and then the HHS secretary, and then there's other.
So you sign off. You get the last word. So here you go. It's we're presenting to you the.
By the way, I haven't gone back to review everything that ACIP has done over the last decade or whatever. So I'm
totally
not.
But you're on the job. So here you go. Yeah. So when it comes to the polio vaccine, he said, Dr. Kirk Milhoan said, it might be time to reevaluate whether that is still needed. He talked about, we've had improvements in medicine, sanitation, and, many factors that have changed since the dark ages of polio. And he specifically said, as you look at polio, we need to not be afraid to consider that we are in a different time now than we were then. Our sanitation is different. Our risk of disease is different. And so all those things play into the evaluation of whether this is worthwhile of taking a risk for a vaccine or not. That's what Dr. Milhoan said about polio. Should it be optional? What are your thoughts on the polio vaccine and a debate about it being optional?
I mean, as a first order thing, I think the polio vaccine is a great vaccine. He's not wrong that the benefit harm sort of calculus for vaccines depends on. So for instance, I think the smallpox vaccine, which was a fantastic vaccine, is no longer needed because smallpox is gone, right? Eradicated from the earth. And so you do want to revisit from time to time. I don't agree if he's saying that we are now in a state where polio is sort of the risk of polio is so low that we don't no longer need the polio vaccine. I'd say I don't agree with that. I think that there's still a risk of polio. Mostly the risk is in Africa, it's like vaccine-derived polio. In Afghanistan and Pakistan, it's still wild-type polio. The risk in the United States is low, but if you were to not recommend the polio vaccine, I think there's a risk of it coming back in the United States. So my inclination, based on
so
my
you wouldn't sign
evidence,
off on that. You wouldn't sign off on that.
well, first, they didn't make a recommendation not to do the polio vaccine.
Okay, so let's talk. You're right. So let's talk about measles. They did say, we have this measles outbreak, thousands of cases, which we didn't have before. And he talked about maybe we need to.
Okay, Mark, I'm pretty sure they didn't make a recommendation about measles.
They didn't. Yeah,
but that wouldn't come to my desk anyway. So I'm not sure what we're talking about.
Yeah, well, I'll tell you.
You're just talking about what the view of one member of ACIP.
The chair of ACIP. He's the chair of ACIP who sets the direction.
Yeah, but Mark, having a range of views on ACIP is a good thing. Like, I think the problem with ACIP before. We're getting back to the title of your podcast. Why should I trust you? What happened before? The way ACIP was run before, it didn't allow a debate. In order to get on ACIP, you basically had to agree with the folks that ran that program.
Yeah, are you okay now with that? ACIP doesn't have, for example, the entire American Academy of Pediatrics.
I would love to invite them to come. I don't understand why they're not at the table. I want a full range of views at the table on ACIP. And let the problem with public health with that whole, like, just let's say with the COVID vaccine, and especially for COVID vaccine recommendations for kids, I know many members of ACIP from that who were on the ACIP in 2021, 2022. The ones I'm closest to told me was that there was tremendous pressure to align with what they thought the CDC wanted. And so the robust discussion the American people deserve to have over whether there should be a recommendation for COVID vaccines for kids as young as 6 months didn't happen. What I want is an ACIP that has a full range of views. Let there be I don't understand why there shouldn't be a robust discussion and debate. And then, the scientific discussion that will come out of that will be richer, and more people in the American public will trust it than if you have this sort of authoritarian top-down kind of approach to this.
Well, the authoritarian top-down approach on ACIP now is that you fired everybody and just picked
Mark, I didn't fire anybody.
Secretary Kennedy
Mark, you got to be. Come on, you got to be. If you're going to ask me to trust you, you got to be specific. I fired literally nobody. I literally just started the job 2 days ago, so I did not fire a single soul.
Okay, but do you at least admit that the entire?
I'm not going to my question. Am I admitting? Do you admit that I didn't fire anybody?
You personally didn't, but the administration.
Okay, so then why did you start with like you fired? I fired whatever.
The administration.
I fired nobody.
I think, Jay, the important thing that I'm hearing, which is interesting, is that you view a committee like ACIP, an advisory committee, they need freedom to explore wherever they feel they should explore, that there should be no top-down parameters on them. And that's your prerogative. That's this HHS's prerogative. That's an interesting view. And I'm just wondering, philosophically, is there a line where you would feel this is now taking us backwards or not a good use of time to explore issues that, we use this phrase that now means so much. I don't know what exactly it means, but settled science that, is there a place where it's just out of bounds where, guys, it's a waste of energy to explore these questions, or perhaps even takes us into sort of dangerous territory where, the messaging out to the American public is confused and muddled? Like, how expansive is freedom to explore for something like an ACIP committee?
I think the fact that, for instance, AAP not coming to the table, the problem there is that that you had a too narrow range of views that were in the sort of Overton window. If when you had that, essentially, post COVID, with the breach of trust that happened during COVID with science and public health, having the narrow Overton window, saying, look, these views that were outside the Overton window before shouldn't be allowed to have their say, is a guarantee that we will never regain that trust. I fundamentally believe, Tom, that having that debate is good for public trust. I think science, science is one of these things where if you don't allow questions that are on the edge, the fringe, if you will, to have some capacity to be in the conversation, it will never advance, and you'll never gain public trust in the context of public health.
What are you doing to bring back AAP into the fold?
I mean, I would, let me just say, right, I've done nothing because I've been in the job for 3 days or whatever. But like I'll say this is that if I would absolutely welcome having AAP members involved at the table. I want the full range of conversation there. I want the American people to see the discussion. Will
you commit to calling them and making that happen?
I call who, I'm not sure, but I've sent out a public message right now.
Yeah. All right. Yeah. So Jay, final question. And thank you so much. I know that like it can be a tough conversation, but I do really appreciate this.
It's a tough topic.
It's a tough topic, and I really do appreciate you coming on. Look, by your own admission, I think you said on Paul Thacker's podcast that when on your first day of starting at NIH, there were like 3,000 people who had gotten rift or something, and that didn't make you feel so good at that time. And there's been disruption, right? Like even if it's for a good cause, it's been something that I think have left. While some people are really excited, there's also some people who are a bit scared of this climate of uncertainty in science. And I just wonder if you can look into the camera and just speak to those scientists who are thinking about maybe leaving the country, are not sure if the United States is the right place for them to do science right now, aren't sure if they can run clinical trials, aren't sure if their labs are going to be funded. Like, what do you say to them right now?
Brenda, the United States is the single best place on the planet to do research. And it has been for now a century, and I think it still continues to be and will be into the foreseeable future. More than 85% of all public funding, non-private funding for research, for biomedical research, including foundation money, including other nations' investments in biomedicine, public investments in biomedicine, come out of the NIH. It's 85%. If you want a future career in biomedicine, the United States is by far the best place to do it. And I think that it's appropriate for us to have research partners, in Europe and other places. That's healthy. I've put in place policies to make sure that can continue to happen on a secure basis. But if you go to those countries, you're not going to get the kind of support that is available for that kind of research in this kind of research that you would get had likely to get here, especially for young researchers. I want to say this. This is that if you're a young researcher, the NIH and the United States are the by far your best bet, especially an American young researcher, because you go abroad, you're gonna have trouble getting research funding from other countries, and the total dollar amounts, the total sort of commitment they have is much less, just as just a matter of, again, math. And the other thing I'd say is for young researchers, in the 1980s, the NIH, the typical first large grant, the age of a researcher getting the first large grant from the NIH was in the mid-30s, and now it's in the mid 40s. It's been creeping up for now decades. We have essentially, and that young researcher that you had play, right? You can hear the angst in his voice about this. Because he was applying for a postdoc. We now require 1, 2, 3 postdocs before you can try your ideas out. That's something I absolutely want to fix at the NIH. It's a cultural shift that's taken decades to get to this point. And what that means is that we have to start funding early career researchers. We have to start funding researchers with newer ideas. And that means that there's going to be upheaval. People who are used to getting grants that are, for 1, 2, 3, 4 renewals 20 years in, where they're doing marginal science, are now going to have a harder time getting research dollars than researchers that are with brand new ideas that potentially can make a tremendous difference in the health and well-being of people. Alzheimer's disease, type 2 diabetes, rare diseases, Parkinson's disease. We need new ideas to advance our in these areas, because there's tremendous suffering. And
can I tell you, Jay, I love that was the first part of your priorities, was training future biomedical scientists. I think the only thing I just want to press you on, just to explain, is that I did see NIH data to show that in 2025 there were like 20% fewer early stage investigators funded than the previous year. What is the explanation? Because I know you care so much about those ESIs.
I mean, I think it has to be organic. I think the way that the NIH has addressed the problems of funding early career researchers has been partly, like, it makes sense, like training programs, but also partly by essentially affirmative action, right? So you have a lower score allowed to be funded because they're early career. It has to be that's never going to work. What has to work is you have to say, we're going to make a commitment to funding cutting edge ideas. And typically it tends to be early career researchers with those ideas. So it's not an affirmative action approach. It's a selecting the best ideas that with a portfolio that includes ideas that if they work out, they can be fundamentally transformative, even though some people may think it may not work out because they're so close to the frontier. Right. I have told the institute directors that they are now authorized to make those decisions. I'm not going to hold them accountable that every grant succeeds. What I'm going to hold them accountable for is that the portfolio grants they have actually advance the health and well-being of the American people. As far as the 20%, I mean, that's, again, there were fewer total grants funded, each at a higher rate. So it's just a 20% versus the other. What's the denominator you're talking about? So a lot of the analysis is sort of that I've seen done on the portfolio is just naive about basic econometrics.
I mean, that came from NIH, so I just wanted to make sure that
but
you have
to have a control group, like 20% relative to what. So I think you got to be the key thing is the structures and the incentives and the systems. And we've set and put in place structures, incentives, and systems to empower the scientists at the NIH to make decisions about the portfolio that are at the cutting edge, that put new ideas out and address the fundamental health problems the American people have with a large overtime window of ideas that are not off limits anymore.
Dr. Jay Bhattacharya, we really appreciate you coming on our show and for your candor and for really just chatting with us about these issues. We think they're really important. So thank you so much for joining us.
Thank you, Brenda. Thank you, Tom. Thank you, Mark.
Thank you so much, sir.
And that is our show for today. Please send us questions and comments at questions@whyshoulditrustyou.net. I'm Brenda Adhikari. He is Tom Johnson. He is Dr. Mark Abdul-Malik. Thank you to Maggie Bartlett on producer job today. And also a big shout out to Kushi Patel for helping us on research. And that is our show. We'll see you back here again next week.